Thanks everyone for coming for the April UCSF Geriatric Grand Rounds. I'm thrilled to be able to introduce our visiting Grand Round speaker, Dr. Jayna Holroyd-Leduc. She's chair of the Department of Medicine at the University of Calgary, as well as the chair in geriatric medicine. On a personal note, I would probably, I may not be in the division of UCSF Division of Geriatrics if it wasn't for Jayna. She took me out to lunch when I interviewed for the VA Quality Scholars Fellowship after after residency when I was at Kaiser. So we've known each other and crossed paths on several occasions. So I'm really excited to hear about all the work that she's been doing, because I know she's had this long-standing interest in trying to figure out how to really have an implementation lens to kind of improving the complex care of older adults. So her talk is entitled Rethinking Continuing Care.
First off, thank you so much for inviting me. I'm really excited to get invited. I'm not gonna say how long ago I was a quality scholar here, but it really did change the path I took. So thank you for the opportunity. You know, as a Canadian coming down, it was interesting. I came down, I moved the week after 9/11. So it was an interesting time to come to the US. So first off, I just wanted to sort of define when I say continuing care, because I think it may not be a term that everyone sort of, what do I mean? So so continuing care basically encompasses, I think no matter where you are in most health systems, we have a form of long-term care, or sometimes called nursing home care, and it's pretty universally the same, right? It's people that need help with basic activities, daily living. They often have cognitive impairment, high functional needs. We often have it's a nurse-based model. But then what the care we provide before that seems to, from my experience and understanding of looking at different systems, varies a lot, and what we call it and what we offer and how we fund it. So continuing care encompasses all of that. And arguably, if you don't put the word facility continuing care, you could also be talking about home-based care, right? So it's all that care outside of acute care that happens as people are aging and starting to live with frailty and complex comorbidities. And so that's why it's to me, it's an umbrella term that doesn't just, I'm not just talking about what we do in the long-term care setting. So just to frame it, and so I want to walk through. Maybe I'll get some context to where I come from now, and then kind of walk through some of the stuff that I've been doing lately, and some of our recent projects, and some of the things where I want to go. So here's a picture of. So my daughter took this from the car, actually. So you can see we still have snow. Yes. So if you think it's cold here, we still have a little snow. So this is the view of Calgary from well, basically from where I live. I do live in the city, but this is downtown. You can see the Calgary Tower there in the distance. So the population of Calgary is about 1.4 million people. We have 4 adult hospitals and a children's hospital. Our children's hospital is relatively new. It was built. I've been in Calgary about 17 years. It was built and opened up while I've been there, so it's relatively new. And then we have a new hospital in the south part of the city too that was open in the last 10 years or so. So that's to serve the 1.4 million. Plus, we actually, if we look at our catchment area, so in Alberta we have what's called Alberta Health Services. So that's a healthcare system, the provincial healthcare system manages all healthcare across the province. And then they break us into 5 different zones. And so Calgary zone is one of the zones. And so Calgary is part of that, as well as the surrounding communities. So there is rural parts that we care for. And then Calgary is one of the biggest cities that provides quaternary care. So we also provide care for all of Southern Alberta when it comes to quaternary, sort of higher level care, and into BC and also into Saskatchewan as well. So, you know, quite a big catchment area of over, I think it's about 2.5 million if you look at it all. So why did I leave the ocean, which I do love, and end up in Calgary? So this is, Calgary's right at the what we call the foothills. And so you can see the Rocky Mountains. So these are some pictures of the Rocky Mountains, and also there's me skiing. And so literally I spent a lot of my time learning to ski as an adult. My kids are big skiers now. Married a skier, had to learn to ski, even though I'm a bit afraid of speed and a bit afraid of heights. So we ski on the weekends, and this is the view, the one particularly A couple of the views are actually views from within Calgary. So we have beautiful mountain views. No ocean, but we have beautiful mountains. So first off, the research I'm going to present is some research I've done more recently. So when I first started, I did a lot of work in acute care. I'm looking at models of acute care, and more recently I've been looking at continuing care. So my research now is been funded by the Canadian Frailty Network, which is a Canadian network that is specifically looking at frailty and involves not just geriatricians, but actually people across the care continuum. So I've been very involved with them, and they've funded some of my work. And then Alberta Innovates is our provincial funder for health research, and the Canadian Institute of Health Research, or CIHR, is similar, would be the same as your NIH, essentially. And then I hold a research chair, which helps fund some of my research as well. And then, I'm going to try to use person first and inclusive language, but if you think there's areas that I could improve, let me know. So we're going to focus on three kind of areas that, so I had to give learning objectives. Oh, I don't know what you're going to learn from me, but so first I'm going to present some results of a project we did. I think it's relevant to sort of probably what's going on in San Francisco and the US, but looking at, an approach to preventing unneeded acute transfers among continuing care residents, particularly the project I'm presenting is long-term care residents. And then look at understanding evidence-based sort of resident-centered approaches to, if we realize that in particular long-term care, life expectancies around, it sounds like it's somewhere here as it is in Canada, it's about 18 months. Really what we're talking about is how do we provide supportive end-of-life care, and when do we decide to do that? And then I want to talk a bit about sort of with a little bit of research time I have left when I'm not running the Department of Medicine, I'm sort of interested in looking at continuing care and rethinking it. And sort of we have this proposal and we've started doing some of it. So I want to present that to you, and we're hoping to get a big, what's called a CFI, a Canadian Foundation for Innovation grant. It's under review right now for several $1 million to actually implement a lot of this stuff I'm going to present, which is kind of, I think it's kind of exciting. So first off, sort of why the rethinking continuing care, particularly facility living continuing care. I think, not dissimilar to what happened in Canada. I think you guys similarly, the pandemic kind of at least publicly highlighted that there's a lot of issues, right, in continuing care, a lot of issues not in facility living, issues I would say we all knew about for probably a long time, but really wasn't getting the attention, right? So the pandemic was a time, particularly at least in Canada, the first wave of the pandemic really hit continuing care hard, which drew attention and really highlighted the need for more research within this sector, particularly thinking of frailty and also engaging residents and family members in care, which I thought, was really maybe one silver lining is finally more broad recognition, right, that we need to invest in this sector. A lot of denial that the population is aging. And that's sort of the next thing is this sort of systemic failures to deal with the consequences that our population is aging. I'm not sure what your stats are like in the US, but I know in Canada within the next 10 years, 1 in 4 Canadians is going to be over 65. I think you guys are not that dissimilar, which is right. And in 2015 in Canada, the number of people under 15 and the number of people over 65 crossed in a direction that we didn't necessarily would have predicted, right? The population under 15 is going down, the population over 65 is going up. There's increase in dementia prevalence. None of this stuff is, you guys all know this, right? And then also this whole, with the change in how we sort of society lives, there's less family caregivers for older adults too, which is going to, all these things are going to have impact. And I think a lot of denial going on around how to address that. So the fact, continuing care is really being challenged on environmental and human resource optimization, and really on delivering, how do we deliver quality of care that also focuses on quality of life? And then I think largely too, there's this big gap, right, in investment in architectural and technology that we could be doing in continuing care facilities. A lot of attention on these smart condos, aging in place, smart hospital units, right? We have one in Calgary that's like the ward of the 21st century, which is probably now outdated in its name, but anyways, right, a lot of emphasis on human factors engineering and acute care and in homes, but not really much thought in the continuing care context. So that's sort of at the end. I want to talk a bit about some of the things that we're proposing to do in Calgary if we can get a commitment for funding. So the first thing I want to talk about is sort of rethinking where we provide acute care to continuing care residents or facility living. And so this is a project that we just finished. So I don't have all the results, but I'm going to present some of the early results. So this was a collaboration across, Alberta has two main universities that have medical schools, so University of Calgary in Calgary, and then the University of Alberta in Edmonton. So it was a collaboration across the two institutions, and then our health provider, Alberta Health Services, and was funded by Alberta Innovates in a really interesting grant. For those of you that are quality scholars, these are grants that are specifically designed to actually implement practice changes into practice and evaluate them in a rigorous way. And then the idea is you scale up and spread them across the province. It's sort of been a great opportunity to, a lot of my research has been funded this way. So this project in particular, prior to the pandemic, about 28 long-term care residents per day were coming into an emerge somewhere in Alberta. So if you think about that, that's 10,000 transfers annually for a population, Alberta population is about 4.6 million. And of that, about 640,000 of them are over 65. So not an insignificant utilization of the health system, particularly if we think about if average life expectancy is 18 months in this population. And the thing that we found was that many of these acute issues could have actually been addressed in the facility if they were appropriately supported, right? So those of you that are, so CTASC scores, I'm not sure if you're familiar with CTASC scores, but it's a way of ED triages. So a higher score means lower acuity. So CTASC score of 4 to 5 is low acuity conditions. So basically it's conditions that probably didn't necessarily need to be seen in an emerge. So 30% of the transfers were that. And then another marker that maybe people were being transferred that didn't need to be is about 70% were not actually admitted to hospital. So identifying that there was a gap here in care. The other thing, so you can see I've referenced Ken if he's on the call, but so we know transfers to the emergency room and acute care, are associated with, prolonged waits in the emerge. And there's some literature that, right, the longer you stay in emerge, the more likely you are to be delirious and other complications, but also in hospital, right? We know infections, falls, delirium, and then, Ken's work around functional decline, right? So not benign for this population, not, the assumption that moving somebody acute care is going to result in better outcomes is a bit of probably a naive way to look at sort of our systems of care. So, and there was also literature, and some of this is coming out of the US, that residents and family actually prefer to receive care within their long-term care setting or their nursing home and not go to emerge, right? And then, so Choosing Wisely Canada, which is similar to Choosing Wisely that you have in the US, there's actually a recommendation that do not send the frail resident of nursing home to hospital unless for urgent comfort and care needs that can't be met in the care home. So that was a sort of a driving, although I noticed the way they worded this is actually not that patient-centered. It should be living with frailty instead of a frail resident. But anyways, I didn't word it. So what are the options then to prevent these transfers? So we know these transfers are happening. We know they shouldn't happen. How are we going to address that gap? So we decided to sort of look at some of the, what was out there and what could we do and how could we put it into an intervention. So first off, we actually stole some tools from the US. So that's sort of how can you detect changes in residents' health status sooner to buy you time, right? So recognizing frail older adults presenting atypically. So the Interact tools, which probably most of you have seen, right? They're interventions. So Interact stands for Interventions to Reduce Acute Care Transfers. So it's a huge bundle that actually the developers, in the US have been very open about sharing, and they were very helpful actually in this project and sharing the resources, and even converted some of the numbers from American to Canadian in terms of value. So it was very helpful. And then we have, I don't know if you have this in the States, but we have community paramedics. That's a resource. So these are not the typical, pick a patient up and rush them to a hospital. They specifically come to provide care in the community. So it could be in someone's home, it could be palliative care, it could be acute care. It's for medical, so these medical sensitive issues that could be addressed, with just a bit of care. And they will come into long-term care and they'll do things like start an IV, maybe give some IV antibiotics. They may transport for imaging that avoids the emergency room. So we want to use community care to help reduce some of these transfers. And we did a systematic review of looking at what's the evidence around community paramedics. So the evidence is pretty poor, but what we did find was that they do reduce long-term care to ED transfers when they're used in this setting. And they also are associated with higher rates of treatment on site compared to the usual sort of emergency medical services where they just pick up and run. And then also, do you think, well, are you just delaying the transfer? No, the repeat calls were less at 48 hours. So they actually were effective at keeping people. So we thought that would be a good thing to look at since we had community paramedics working in the Alberta context. And then also can never hurt to actually communicate better. So we have a centralized call line across Alberta, and it's to connect MDs to MDs, and it's primarily was designed for transfers between a community hospital to a quaternary care hospital, right, where you talk directly. So a general internist, say, looking after a patient in a community hospital that needed to transfer someone, say, for an urgent cardiology assessment for potential cardiac surgery, can speak directly to that person and not go through the emerge and do a direct transfer. So we were able to get this service to actually consider being sort of acting as a central connection between the long-term physician and the ED before transfer, so they could have a dialogue. Which I'll talk a bit about. It wasn't just about sort of making decisions necessarily about not transferring, but also if the transfer is going to happen, make it very clear, this complex patient, this is what they're like at baseline, this is how they're changed, this is what I'm concerned about. So they don't show up and emerge with very limited sort of understanding of the patient, and then you go down that whole rabbit's hole of doing investigations for things that have been chronically already dealt with. And then we had a very active resident and family advisory, what they called themselves advocacy group that was very involved throughout the whole project, that helped drive this project. So from this, the solution we came up with, what we wanted to implement, was this centralized and standardized long-term care to ED care and referral pathway. And so it was supported by using this, what we call RAPID. So that's what we call our centralized call center, community paramedics. And then we incorporated 2 interact tools. So the stop and watch, which healthcare aides can use. So it's basically a tool that empowers your personal support workers, or I don't know what you call them in the US, we call them healthcare aides. So it's basically your frontline basic care providers that are doing the day-to-day care in facilities. Often, at least in Canada, they often are racialized women that are relatively new to the country. Aren't very typically that empowered to communicate. So this tool has been very helpful because it helped give them words to things that they were seeing, right? The atypical changes. It helped give them a way to screen and then to communicate that. So very useful tool. And then for the nursing staff, there was a change in condition cards, which helped them once the healthcare aide had identified there'd have been a change in the resident status, to help them sort of figure out what to do before that would then call the physician to get involved. And so this was the pathway where people had options. We could, we said you could still decide to send somebody right to emerge. That was never going to be, if that was the right decision, that was fine. They could immediately do whatever they could do whatever care they felt they could do without involving anyone. And they also had direct access to community paramedics without having to go through this pathway. And then the one part we sort of added was this connecting the ED physician to the long-term care physician, as well as the long-term care nurse, if the long-term care physician wasn't actually on site, where they could have a dialogue and make a decision around transfer. So that's sort of the standard pathway. So basically what we did is we took resources we already had available and kind of put them into a more process map to follow for clarity around decisions. So this was basically what the intervention was, is the long-term staff would identify that acute change had happened using the interact tools. Then they would notify, so that would be the healthcare aides. They'd notify the nursing staff, who would then talk to the long-term care physician, who would then determine what pathway they wanted to. If they wanted to use rapid, they would call, and get connected with the ED doc, and then they would decide, to transfer or not. So that's kind of the simple pathway. So we didn't start anything particularly new. We just kind of took a bunch of available resources and put them together. So our study was a mixed method study. So we had 40 long-term care sites. That's all the long-term care sites in Calgary that were eligible. We have a few that are already attached to a community hospital in rural parts, so that would be excluded. But pretty much every long-term care site participated in our 4 emergency rooms in Calgary. So as I said, the population is about 1.4 million. We used a randomized stepped wedge design. We implemented, our timing couldn't have been any better. I say that sort of sarcastically. We started October before the pandemic. And then the pandemic hit and we decided, we're going to keep going. Even realizing the pandemic is probably we kept going. So this pathway was sequentially implemented. And what we did is we had, out of the 40, we put them into 9 cohorts of 4 to 5. So typically how we decided the cohort is if a long-term care provider had multiple sites, we would put them together as a cohort, recognizing they would often share staff, right? So there was no point in, if we didn't implement them all together, you'd end up contaminating the staff. So we sort of logically put together the cohorts, and then we randomized the 9 cohorts as to when they would get the intervention, and they would stay in usual care until then. And every quarter we implemented to a new cohort. That's why it took us from 2019 to 2022 to finish. And then post-implementation, we had quite a rigorous evaluation plan, which we had to actually kind of put aside because we couldn't get into the facilities to do a lot of the, so some of the, we still had enough outcomes, but we did lose some of our outcomes. We were able to still do some post-implementation interviews with healthcare providers. We wanted to do interviews with residents and families, but actually couldn't recruit any, I think, just with the pandemic and the waves, and we just haven't. So but we did get a pretty good smattering of healthcare providers that were involved, that would have been impacted by the pathway. And so, as I said, the implementation was the pathway and it was supported. So how we implemented, we had a implementation coach who was actually a geriatric nurse educator that actually went in, at each and would implement, did some train the trainer model with the nurse educators in the facilities. We also did use, standard implementation strategies to figure out what local barriers were. So we had them do a questionnaire where they figured out their top barriers, and then they developed their implementation strategy to how they were going to implement this pathway. So using, standard KT techniques. So in particular, those of you that understand, we use Michi's TDF framework to actually figure out barriers and then come up with a plan. We also used audit and feedback reports so at baseline and then quarterly post-implementation, the sites would get feedback on how they were doing, like how did they compare to the zone averages in terms of transfers and hospital admissions. So our main outcome was looking at the change in rates of transfers from ED to long-term care. We adjusted it for resident days to adjust for the difference in facility sizes. Secondary outcomes we were able to achieve was we looked at our hospital admissions adjusted. We looked at community paramedic visits. We looked at the call service use, and then qualitatively we did interviews. And we're doing a cost analysis, which I don't have the results yet because they're still working on it, although the preliminary results do suggest it's cost effective, mostly because, as you'll see, the impact we had on hospital admissions. So here's our quantitative results. So this is the incident rate with 95% confidence interval. Because it was a step wedge, so in a step wedge where you sequentially roll out in a randomized fashion, the sites end up acting as their own control. So it's like a quasi randomized control trial. So we were fortunate Alberta Health Services has a PhD statistician that actually did the analysis for us. And so you have to adjust for the fact that they're their own control. But what we did find is our transfer rate. So if you look at the transfers per 1,000 residents before the intervention, it was 1.92, went down to 1.7. Hospital admissions also went down from 1.03 to 0.91, and then rapid calls increased. So there was more calls. The interesting thing is the visits by community paramedics actually went down. And this is because this is the one impact the pandemic had on our intervention is community paramedics actually were discouraged from going into facilities during outbreaks and during waves, right? So, so the intervention was positive despite it was not being driven by community paramedics, why is that? I'll talk about it in a bit, but our qualitative analysis has shown some interesting trends. So this is a bit busy of a picture, but the main thing is we interviewed 22 providers across the whole care continuum that would have been involved with this pathway. And they found that there was value to the rapid, so the value to this MD to MD conversation, which they're continuing. Everybody had a desire to do what was best for the residents, maybe didn't agree what that was. This interesting thing is the lack of knowledge about what others could do. So really a lack of knowledge of scope of practice, particularly I think the ED not realizing what the facilities could offer and working very much in silos and fractured community practice. And then the interesting thing is the power dynamic is who actually ultimately is the decision maker, right? So, how often was a family member overriding the decision made by the care team on site about transfers. So we're still working on the qualitative analysis. But overall, we did see transfers from long-term care to ED and hospitalizations decrease. It wasn't a result of community paramedics. I think personally what it is the Interact tools, combined with the fact that during COVID, at least in Canada and in Alberta, our facilities, there was such a push to not transfer patients that they let long-term care facilities do more. So they were using a lot more hydrocolysis. They had more access to labs and imaging, and potentially even could put in IVs potentially. So they were able to do things that they couldn't do before, that they would have had to rely on community paramedics, which is probably why they didn't need community paramedics. And the government was funding that. It wasn't having to be funded by the facilities, which normally would be. So this may not continue those, of course, because that's what the government has told me, even though we're saving them money. The facilitated conversations between physicians also was felt to be value, better care when they did arrive, and more ability to, do that, whatever they needed done and send back. And so we're looking, so the pandemic overall, the study was designed to account for secular trends. So I don't think that was an issue, but as I said, the biggest thing was community paramedics. And then I've talked about the provider perspectives. Really, we need to work on, sort of this understanding of what can be offered across the care continuum, I think is the biggest driver we're gonna learn. So we're completing our cost analysis, and then we have a funding model that I'm gonna apply for. We'll actually be able to spread this right across the province. We're gonna publish it, obviously, and so just in that process, and we've actually designed an online implementation resource that could be used as well. So that moves to the next section. So if I said, so we've got a population that, is 18 months life expectancy. We don't want to get them into acute care if we can avoid. So how do we actually look at supportive end-of-life care? So this is another project that I was involved with that the Canadian Frailty Network funded, as did my chair. My chair funded a postdoc to do a lot of the work. So in this setting is sort of what I've said, as long-term residents as a population are frail with a lot of functional and cognitive impairments. They require assistance with activities of daily living. They have high prevalence of dementia and cognitive impairment. So in Canada, that's about 80% of them have some degree of cognitive impairment. I think it's probably similar here. Really complex healthcare and care needs, right? Nearing the end of life. So a third of long-term care residents in Alberta have what we call comfort level goals of care, which is basically non-invasive, not transferring, focusing on quality of life. And then we also know there's a high burdensome of symptoms, right, and pain and responsive behaviors in this population. So there's a number of barriers, though, that the literature suggests in terms of providing supportive living and end-of-life sort of supportive care. And I'm not calling it palliative care because, it's more about supporting what they need at the end of life. But so some of the barriers are right, the population can't always communicate their needs because of dementia, the unpredictability of the dying trajectories for frailty, right? The barriers to discussing dying in our cultures. Very high workloads going on, right? So I'd be interesting to see if we've increased our levels of care providers as the patient population in long-term care has gotten more complex. We actually match the service that's being provided. I'm guessing, maybe Kenneth will figure that out for us, but I'm guessing the answer is no across both US and Canada. And then also just knowledge and skills, right? Not like around palliative care, particularly those that are doing the day-to-day care. And then, like I said, this over-reliance on acute care. So our objective here was to actually look at, so we knew at least some literature that other sort of, we have a big group of nurses that are looking at supportive end-of-life care and long-term care in Ontario, and they'd looked at the other providers, but didn't actually ask physicians. So we wanted to ask the physician's perspective around what were the barriers and facilitators to this kind of care. And then we wanted to start to look at, developing sort of how could we do evidence-informed end-of-life care practices and tools that targeted the barriers that we'd identified, and using a team-based approach. So that was this project. So the first part, the role of physicians in long-term care. So as you know, I think it's pretty similar no matter where you are. The physician's there to manage the medical, acute and chronic, address cognitive and mental health, deal with function, there to lead sort of the team. But like I said, we don't really have a good sense of what their perspectives are, at least from my review of the literature. No one's really asked them what did they think the barriers were to providing this effective end-of-life care. So we conducted a descriptive qualitative study. We did semi-structured telephone interviews. We did qualitative content analysis. So we used Michi's theoretical domains framework. So that's the TDF, which looks at 14 different areas of potential barriers to change in the healthcare context. The transcripts were coded and themed. And then the themes were reviewed by the whole research team. We ended up interviewing 23 family and palliative care physicians that worked in long-term care right across Alberta. So like I said, population is about 4.6 million. And so who we interviewed, it was about half female, half male. They were a range of ages, had a range of duration in practice, and they came from a range of sort of settings. So a lot of them did practice in sort of large to medium density areas, but we did have a fair number of people practicing in smaller communities and rural communities, or some that practiced in both. So we felt that we had a pretty good array of providers that were giving us input. So I'm not going to get into, there's a lot more details, but I'm going to get into sort of the main themes that we found in terms of barriers. So the barriers identified was, one was managing expectations of frailty and care management, particularly focusing on some uncertainties around pain management and also related to using medications in the context. Then there was also a big theme around dealing with the psychological and spiritual concerns associated with end of life, and then the complexities associated with end of life. So sort of the knowledge and skills of diagnosing, prognosis, treatments, and outcomes when, you know, the big driver was frailty. So those are kind of the big barriers that they identified. And then what they thought was facilitating was having standardized tools. So several of the facilities use standardized tools. They thought that that was good to help them set expectations, particularly across the care providers and the families, using available resources when they were there. And then some places had specialized training for physicians in long-term care, which was helpful. So those are the facilitators. And so out of the main messages of the interviews was that supportive end-of-life care for frail individuals is complex and unpredictable. But the interesting thing didn't come out in the themes, but the interesting thing was families actually expect some degree of clarity and certainty. So a lot of uncertainty but people want certain, which is not, that's human behavior, right? We all want control, we all want certainty. So that's not surprising. Also this need to provide education, training, and mentorship, and how do you do collaborative supportive end-of-life care and long-term care? And then the need to provide access to palliative care and also other community resources, right? Not leaving long-term care facilities to do all this in isolation, right? Connecting them with needed supports. So the next step was we wanted to look at, so what actually did the evidence suggest we should be doing in long-term care? So we did a bit of a mini systematic review looking at supportive end-of-life care interventions. So followed the PRISMA criteria. We found 25 publications of intervention studies. They were kind of low quality based on the grade assessment. Most were sort of this pre-post design. There was one RCT that looked at palliative care. And it was, the interesting thing is the interventions identified did align with a lot of the physician identified barriers and facilitators. And I'll go through what the interventions were. So what this systematic review found was there was 5 kind of interventions that there seemed to be at least some, although maybe low quality, some evidence. So first was providing access to palliative care consultants is important. Second was engaging residents and families in discussions about goals of care, treatment preferences, and palliative care early. So that's low to moderate evidence for both of those. Early identification by long-term care staff of residents whose conditions has deteriorated and appeared to be at high risk of death, and communicating that to the physician. So back to that whole interact tools, although the evidence is low, I think that that's important. 4 was the providing long-term care staff, so the healthcare aides and the nurses, with education and training about how to provide supportive end-of-life care. And then the last was, interestingly, there's actually some literature around having access to spiritual care services within continuing care. So we took that, what we knew from sort of the barriers in the literature around other healthcare providers, what we learned from the physicians around barriers to facilitators, we took the evidence from the literature search, and we did a Delphi, or modified Delphi, to kind of start to develop an end-of-life care strategy that could be implemented in long-term care. So we did 2 rounds of a Delphi. So we did a purposeful sampling of stakeholders from across Canada. So we sent it out to 65 stakeholders. They were physicians, long-term care staff, and administrators. They were long-term care residents and family members. We also had palliative care and geriatric or gerontology experts and researchers. So our process was we developed a questionnaire using the interviews and the literature. We ended up with 75 statements that the participants ranked on a 9-point Likert scale, with the threshold of appropriateness being at least a 7. And then the statements were sort of aligned with the 4 subheadings that we had identified. So managing pain and other symptoms, managing end of life, long-term care context, and then topics related to families and family issues. So with the actual Delphi, the first round, we had 18 participants. They were from a diverse group, and they were from across 3 provinces. All of the 75 statements all ranked above 7 in the first round, other than 4. So the second round, we just sent back the 4 statements with some clarifications, and they still ranked below 7, so they were excluded. So we ended up with 71 statements that remained in our Delphi. So the main findings, so there was, I'm only going to give you the ones that ranked sort of the highest and the main subgroups to give you kind of a flavor, but like, I don't want to go through all 71 statements. So in terms of managing pain and other symptoms, the main thing was that among persons with dementia, it was important to include family when trying to understand their responsive behaviors. And among persons with dementia, it was important to identify underlying factors associated with their responsive behaviors. So both of those were ranked high by the people that participated. Managing end of life. So the first one's underlined because that was in the evidence, right? We have evidence-based strategies for doing this. So this engaging residents and families in discussion about goals of care and treatment decisions at end of life was important. Collaborative approach to care improves care by improving communication between team members. A documented palliative care pathway would help to identify changes in patient status, manage expectations of the staff and the family, and organize the provision of care. And that it was important to have private, this was interesting, I thought, was identified important to have private spaces within the facility for the patient and the family near the end of life. So actually moving them into private, right? So the was deemed as a very important intervention. In terms of the context of providing supportive end-of-life care, so this was an evidence, right? Both of these came from statements were actually from, evidence of interventions that had some evidence, right, of working or ranked high. So providing long-term care staff with education and training about supportive end-of-life care, and then having access to palliative care consultants, right, that were actually involved in long-term care. Like on site. And then the relevant to top families was just the importance of involving families in conversations about care. Was felt to be important. So then the next step we did is we actually had a consensus meeting to further develop this end-of-life care strategy. So we brought together a variety of long-term care stakeholders. We presented the results of our qualitative study, the physician study, the systematic review, and the modified Delphi. Our goal at this meeting was to prioritize end-of-life practices and begin to develop accompanying implementation strategies. So we had 35 participants, a range of including some family members, and we used a World Cafe discussion. So that building where you go from discussion to discussion, you build on discussions, looking at the 4 targeted areas from the Delphi. And in the end, we have a paper around this, but in the end, we kind of came up with this sort of overall theme that there's 6 main things to improve supportive end-of-life care and long-term care. First is the need to restructure physical setting. So, in terms of fronting care, so that would include the things like private spaces. The need of education and skills training was felt to be very important. The need to build collaborations between care providers. Interesting too, the need for media campaigns to actually change your public perceptions of long-term care. And then 5 was involving families in care discussions and responding to their concerns. And 6 was, interestingly, broadening the definition of frail older adult to reflect the diverse health conditions. Right. And so, which other realms, when I look at literature I've done with the Canadian Frailty Network around frailty, there is a lot of debate around what we mean by frailty. So the key recommendations coming out of this was we needed to create policies and provide funds for extra staff and comfort care needs at end of life. We need to establish knowledge and training expectations and resources for staffs and the physicians that focused on palliative approaches, mentorship, communication, collaboration. And we should build connections between long-term care and the wider community, and also work to change public perceptions. So what we've done since then is we've actually gone on to develop a frailty care pathway for long-term care. So this pathway was developed for residents living with frailty and long-term care. It was funded by CIHR. We used evidence from the work that I just presented, as well as evidence around sort of frailty detection, diagnosis, and management. And we used a modified Delphi procedure to develop the pathway. We've created this pathway to sort of focusing on strategies to delay progression of frailty, as well as identifying and initiating early palliative and symptom management, and having better end-of-life care approaches to care for this population. So right now we're implementing it with, we got a grant from Alberta Health to actually implement the pathway in long-term care. So we're exploring potential barriers and facilities to implementing, and so we did a lot of interviews to figure that out. We're using the query implementation model, which comes out of the USVA, which I love that model actually for implementation. So we're starting with a pilot unit and we're expanding it beyond and eventually going to go across the whole province. And so our similar implementation strategy to the other project where we have a geriatric nurse educator that's implementing, we're doing a train the trainer, we're using printed resources as well, and we're addressing local barriers using known KT strategies. And we're going to do quite a rigorous mixed mixed method evaluation. So this is sort of where the quality improvement comes in. So this is, for those of you that are interested, this little picture of the queue is the Health Quality Council of Alberta developed their own 6 dimensions, which if you look at it, it's not dissimilar to the Institute of Medicine one, although they have a few that are a bit different, but similar. So in Alberta, we often use this. So our primary outcome, though, is change and uptake of the frailty assessment of older adults in long-term care, so effectiveness. And then we're going to look at how effective is implementation using the REAIM framework, which looks at reach, effectiveness, adoption, implementation, and maintenance. And then we're going to do a cost consequence analysis. Pretty much anytime we do sort of interventions like this, particularly when they're funded by the government, they want to know what's the cost consequences. So now this is, so the last sort of 15 minutes, I'll try to get through this so we can have time for questions. I know we got started a little late, but this is kind of what I'm getting most excited about is this whole idea of I want to create what we're calling an experiential ecosystem for innovation within operational continuing care facility. So the exciting opportunity around this is sort of my role as academic lead of the Center on Aging. So we had a new Render Stafford Foundation is a not-for-profit organization that operates, I think they're 5 or 6 facilities now in Calgary area, and they have a very close relationship with the university. So they actually provided the funds to set up our Center on Aging, and they fund one of my chairs. They fund another chair in Alzheimer's research at the university. They actually built a facility which has long-term care, but also has what we call supported living, or you guys would call assisted living in it. And so, and it's right, it's literally behind our children's hospital, right beside the university, which is also very close to where I work, our main academic hospital, the Foothills Hospital, which has our health sciences. So it's within walking distance of all that. And what they actually have is the Center on Aging is actually physically inside. So not dissimilar to kind of the Baker's model in Toronto, but we have space right in there. And the idea is that they actually wanted to take the concept of developing a continuing care unit of the future. So they've actually devoted 34 resident rooms, so a whole unit, to actually doing these sort of initial types of interventions that we can then spread across the whole facility, spread across all their, other 5 facilities. And then because of the relationships that we have in the Center on Aging and they have with their other care providers right across the province eventually. So the idea is that they've actually committed 4 of those beds. We're going to, if we get pending funding, we're going to actually develop 2 A/B test units. So this is a collaboration with, University of Calgary has a faculty of architecture. So we've collaborated with them. There's the dean is very interested in looking at how do you, adaptive sort of living environments for people with care needs. So he's developed this interesting model called the Laneway House. If anyone's interested, I can tell you it's a whole side thing. But anyways, he's very interested in looking at, getting into and actually where they'll actually develop architectural designs and features, and we'll actually do A/B testing, where with the 2 sites to kind of get at a sense of, because I had no idea, like when you talk to the Dean of Faculty of Architecture, he says, like, for the most part, architecture is actually driven in real-time building. So it's all rules of thumb, it's all generated. A lot of the designs of facilities are based on the needs of veterans in terms of disabilities, which is very different than actually who's living in long-term care. It's outdated. It's never done. It's done in real time. It's done in the constraints of a real build. So this is sort of a novel idea that you do it outside of that context and actually be able to look at so I'll talk more about that and sort of as I go through. They also wired this unit so we could support research. There's also outdoor recreational structures, so we can look at outdoor spaces. And then in the Center on Aging, using funds from my chair, we actually devoted some space specifically to a qualitative lab, so you could do on-site qualitative analysis. Our end users are very involved. And then, like I said, it's supported by our Center on Aging, and I've already discussed sort of its location. The other interesting thing is this facility is attached by what we call plus 15. So in cold Calgary, we like to attach buildings. So there's actually a above ground. I don't know why it's called plus 15. I think it's more than 15 feet. Maybe it's 15 meters. I don't know, but it actually is this facility is connected to a seniors facility, and we have a smart condo in that facility. So we'll also be able to look at sort of aging in place designs. So what this is, we put in a big grant to try to get funding. We've used some other funding sources, but the idea is creating this experiential ecosystem to study how do we optimize the lived environment of those with frailty and multiple morbidities. We want to focus on innovation research capacity within the continuing care context. sort of rethinking regulatory environments and industry standards for how we design and manufacture various things in the context of continuing care, long-term care. Study the impact of innovations on residents and the workforce as well, and their well-being, experience, and outcomes. And so this is actually a collaboration. There's 6 University of Calgary faculties that are involved in this collaboration, and we have national, international collaborators, including in Australia and the UK. So the main 3 themes that some of it we're moving forward with more than others. So the first one is around looking at the environment. So the idea is to design and iteratively evaluate innovative architectural features and architectural and industrial design products and innovations that look at optimizing the physical nature of the living and working environment. So both indoor and outdoor, and we've actually started looking at some of the outdoor. We're doing some outdoor environmental things focused on gardening. So we have a research at U of C and also at Mount Royal University, which is another university in Calgary. It doesn't have a medical school, but interested in looking at outdoor environment and how does gardening in the outdoor environment impact the setting. Then we're also going to look at functional capabilities. So this is applying and studying technological innovations, evaluating and optimizing the physical and the psychosocial aspects of aging. I'll talk about some of the things we're doing. And then the third is the workforce and residential experience, sort of thinking about models of care and professional practice and just the work environment overall. And I think the pandemic highlighted, right? It's not the best place always to work in. So the first thing I talked quite a bit about that the indoor, the A/B testing and sort of looking at developing architectural industrial prototypes. We need this funding of this, what's called the CFI, the funds to actually move forward in this because this will be quite expensive. But the idea is we'll be able to kind of hopefully change building guidelines and actually develop some patents and new architectural industrial design innovations that should hopefully will change and revolutionize the environment. The outdoor stuff I talked about too, in terms of looking at the therapeutical potential. So we're going to put in some gym equipment that is accessible to all. And the idea is we're trying to look at it. How can you actually, with the outdoor spaces so this facility has an indoor, or not indoor, but a centralized area that so people with dementia can be in there without getting lost. So we can put some gardening stuff in there, but also the spaces around the outside to bring the community that put in equipment that is accessible to all and then study how is it used. We're looking at trishaw bikes too, which are the bikes right where people can sit at the front and bike, and then using gardening. So we're moving forward in some of these areas this summer to actually sort of test and look at how can knowing that there's some evidence that this could improve quality of life. In terms of functional capabilities for theme 2, the main 2 projects that are undergoing is robotic pets. So I'm sure you guys have seen those robotic kittens and puppies that are probably all over facilities. There's actually not a lot of literature around how they should be used or whether they're effective because they're pretty inexpensive. I think they're under $100 now. So we actually have purchased some, and we're actually have a gerontologist that has a background in qualitative that's working with our rec therapists in facilities to actually look at how does it improve social engagement, but also physical activity. So they're looking at some, how can you actually use them in a way that, so kind of an interesting study. And then somebody in the Faculty of Nursing who also has an interest in biomedical engineering is looking at, so I'm sure you're familiar with reminiscence therapy. There's some evidence, right, for using that of dementia, right, where recalling past memories to sort of value belonging. She's looking at using virtual reality to implement reminiscence therapy. So that we've bought the equipment and that study's underway. We also, our Faculty of Engineering in Calgary is very interested in something called positive technology. So technology that's designed to support well-being. And so then once we get funding, looking at studying passive monitoring to predict, can you predict adverse events? Can you predict that someone's going to fall before they fall while protecting their privacy? So looking at infrared, near red kind of technologies. So, that able to predict behavioral patterns and also actually monitor individuals' actions. So these debt-based privacy preserving, so you don't actually know who the individual is, but you can detect changes. So beyond me, it's the Faculty of Engineering, but they're very interested in kind of getting into this space and looking at that. And then we also our Faculty of Kinesiology wants to look at, can you use adaptive physical activity, things like, recumbent bikes and walking treadmills and things that actually in this population, study how does doing this sort of activity impact how their brain ages and their cardiovascular health and their sleep patterns as well. And then also lots of interest in wearable technology at the University of Calgary. And so they want to look at some wearable technology in this population, right? Look at it, study it before we start using it, right? Which tends to be the go-to, right? We just start using something and not really know how to use it or why we're using it. As far as the workforce, a lot of this is already underway. Some of this is stuff I presented. So looking at sort of technology and clinical practices that are innovative. The one really innovative is the same person that's doing the virtual reality reminiscence therapy also has an interest in looking at healthcare workforce back injuries. So we bought the sort of the equipment that she needs to, where they're actually going to collect biometric data to develop predictive models of who might injure their backs. And so using artificial intelligence sort of for real-time feedback to prevent back injury, because it costs billions of dollars, right, every year, this injury. So I think this is really kind of a novel, both for the healthcare worker, right, to prevent them from injuring the back, but also from a healthcare system perspective. So this is a collaboration between nursing and our biomedical engineering group. So that this study is just underway now. And then as far as workforce and resident experience, we're doing similar to the frailty pathway. We have other pathways where we're looking at, how do you use evidence and implement pathways, but in a meaningful way where we actually sort of look at outcomes. Do we have impact on symptoms and quality of life? And then the Faculty of Law is actually, there's a lawyer in the Faculty of Law that's very interested in looking at sort of regulatory frameworks and what's the sort of that tension between practice innovation in particular and quality of life and regulation, right? And kind of wants to study that is, does regulation actually get in the way, or is it actually, when does it get in the way and when is it actually positive? And so she's going to be exploring that in this context using our qualitative lab. So that's kind of what I've been up to most recently. Happy to open it up for questions and comments.
Person, I actually get to give you the plaque.
Oh, I get a plaque.
Exactly. Sometimes you just have to mail it to me. So anyway, thank you so much for that fabulous talk.
Well, thank you for the plaque.
And this is our plaque, and it basically says "Teacher Affects Eternity." It has your name and
very nice.
So thank you so much for being here. I think I'll take the first question as people are thinking. I think the architectural or just improving the well-being is super interesting. What measures do you think you're going to have to show a benefit to have anyone fund it? Like how do you incorporate this into other nursing? Like, how are nursing homes going to take this on? Or I guess that's the question always.
So I'll try to answer it with not being the architect. So the architect that's involved, so the Dean of Architects has developed this, what's called a laneway house, and he wants to use this concept. So what he developed was, by laneway house, it's basically this portable structure that you could stick in the back of somebody's yard, and it actually incorporates all the things you need to live, plus oxygen and medical devices and stuff. So his idea is take that traditional, like, hospital looking kind of style of bed, and how can you actually take easily fabricated units to make it look more like home, make it feel more livable, but also incorporate that technology. So I think they're going to do it in a way, so they're going to fabricate it all at the using machinery that they have in the School of Architecture. And we also have funding a portable fabrication lab that they'll actually be able to deliver the products into the facility and actually do some fabrication on site. And so I think it'll be done in a way that actually that is sort of cost effective, like, right? We're not talking about, right? But it's interesting because from a health, like he kept saying, I'm not a traditional researcher, although this guy's an award-winning architect that actually was an award-winning architect before he went back and did his PhD. Is how they evaluate things is very different than us. They very much like the A/B testing model, and they're much less rigorous. So he feels like anything he does is going to be more rigorous than they're used to doing in this field, which I thought was really fascinating, right? Because for our standard, it'd be like, why would 2 units have anything to do with, like, so it's actually real-time end user evaluation and testing, right? So I guess and that's how they drive. Apparently that's how they drive architectural design and regulation, is all just based on this. Yeah, that's what he's told me. So I don't know any different. Someone knows differently, but yeah, it's not nearly like, so fascinating, that all these things we do are not that particularly based on. But he does factor in, they look at costs, and they'll be able to, like, because they'll be fabricating it, so they'll know what, you know, what potential, so in terms of patents and things like that, so. So I don't think it would add necessarily. Now, it might add, there's a lot of work in Australia looking at renovating. I don't know if there was a guy that did a lot around renovation of facilities to make them more user-friendly. He's now retired, but his name's Flemings. He's a PhD that did a lot. He's now retired, but he's involved in the project too. And so using some of his strategies too around how you can actually renovate facilities in a cost-effective way. So he's done a lot of work. And so the idea is to kind of marry some of the stuff he's done too. He actually came from Australia before the pandemic. He's been twice to sort of visit us and start some stuff there. So I don't know if that answers your question, but.
Long-term care. One of the things that discovered and talked about was how there's definitely a recognition among frontline staff in long-term care that many of the transitions could be avoided, but it's kind of this dynamic of it's clearly not quite right. They don't necessarily feel, so it's kind of a crisis situation.
Yeah.
They don't have a lot of slack in terms of additional resources, whether it's additional nursing time, nurses' aid time. Sometimes they are not always able to get in touch with the physician. And the family is like, well, grandma clearly isn't right. And you are just a nurse's aide or just a nurse. And so it was very challenging to see. And I think that's one of the reasons why she was focused on kind of telehealth as a way of getting, but it made me, I have to say, the research made me somewhat depressed in that, I think the fundamental problem is this is such a high need population, and long-term care is a relatively resource poor setting compared to acute care, and that's the thing that's driving. It's like the family member saying, something is wrong. We have to throw additional stuff at grandma to help her. And the only easiest way to do that is to
send her off. Yeah.
Send her off to the emergency room where they have, down the hall, and they have 500 doctors within a half a quarter mile radius. So anyway, I'm sorry, that's not a question.
No, I mean, and that actually, and it probably still goes to some, but that's exactly sort of what was going on, right? Is this limited resources and no options, right? So I'm actually becoming a huge believer in those two interact tools, particularly the stop and watch. We actually give the healthcare So what I've heard from them is it empowered them, it gave them language, and so instead of just coming up to the nurse and saying, something's wrong, this person's changed, and like, what do you mean, right? And it could be easily dismissed, as they actually have the words, and so it was taken more seriously. And then apparently the change in condition cards to help the nurses to triage it. So then they were picking things up earlier, which buys you time, right? So then you could wait till the morning to get where you have access to the lab, or you could get, and the idea was that the paramedics could maybe come in and do some of that. I don't know if it's in the States here, but in Canada, like some of the nurses, you have to, in order to put in IVs, you have to do so many, right? And there weren't enough IVs happening on the units for them to maintain their competence, even if you trained them, right? And so that became a bit of an issue. So hydrolysis has been more of a saver because it's easier for them to do. So that's helped with hydration stuff. And then there's also portable companies that have kind of used, they'll come in and they'll do they'll do the imaging, and they'll do simple imaging, or they'll do labs. I mean, that's a for-profit even in Canada, right? And that's where it gets interesting, because typically that meant the facility pays for it, or potentially they charge the residents, like, right? Versus if they come into the Canadian acute care system. So, but during the pandemic, apparently the government was a bit more willing to pay to keep them out of, which is where when I said that. So, right. So exactly, we have the same challenges. It's like, really, you could invest a lot less dollars by just like with all these portable, again, and the community paramedics, right? Because community paramedics have all those skills to do that simple stuff, right in there, and extra hands on, which is why we thought the community paramedics would be, because they weren't going into long-term care when we started this project. But then, like I said, the pandemic. So I'm not sure moving forward that we may utilize our community paramedics more, because as the government starts not letting the facilities kind of have this easy access to stuff. But yeah, I mean, that's an ongoing challenge, which is sort of why it's actually, it was a driver of this pathway, and also a driver of the getting that access to the long-term care physician to talk to the ED physician. So because the other thing that's what we've heard from the qualitative is sometimes that was powerful to be able to say, you know what, I've talked to an emergency physician that agrees that they have nothing more to offer, right? Like, yeah. So I think as we learn, we're still valuing the qualitative piece, so really tease out some of that. But yeah, there's definitely some interesting learnings from.
Exactly on that, that I work a lot in assistance, and they have regulatory issues. Have to call 911 and get the residents. So in order to do watch and wait. On the one hand, it's good. They don't have staff there.
Yeah.
Really frustrated. So.
Well, and similarly, we have like our supported living is similarly like less like, right, there's less nursing, it's more healthcare aides and maybe LPNs. We do have nurse practitioners often instead of physicians, but we did, you know, like, so we don't have that regulation. They don't have to mandate the transfers, but often that was the default, because even more so. And so we actually had a separate project where we just did the stop and watch and the change in conditions, and that actually, we did show that alone decreased our transfer rate, I think, just because it was picking stuff up sooner. The most complicated model to that, though, was like in long-term care, there's a very clear physician model. When you move into long-term care, you have to have one of the long-term care physicians. I don't know how it works here, but in our supported living, you can maintain your family doctor. So the most complicated thing to the pathway was trying to figure out who to call, what physician to call to actually get there to, right? Because there could be 200 physicians associated with one facility, right? So that was more so than, I don't think we have a regulation where they have to transfer. But that gets at that whole, like, there's somebody in our faculty of law that wants to look at that kind of stuff, right? How often is our regulation actually preventing us from providing high quality patient-centered care, right? The whole, you know, right, the need around, especially when patients have dementia and responsive behaviors and the approach to care, right?
Thank you so much.
Oh, thank you.